It's my pleasure to
introduce Rajeev. So he brings a wealth of expertise in both clinical care and national collaboration in the treatment of amyloidosis and related blood disorders. Rajeev is a consultant haematologist based in Middlemore Hospital with a dedicated interest in myeloma and AL amyloidosis. His commitments to improving outcomes for patients extend beyond the clinic, as he represents New Zealand on the Australasian Myeloma Registry, contributing vital data and insights that shape best practices across the region. In addition to his public hospital work,
Rajeev also practices privately at Mercy Specialist Centre and Auckland Oncology, where he continues to support patients facing complex haematological conditions. We are honoured to have him here today to share his perspectives on advancements in the management of AL amyloidosis and the evolving role of collaborative research. Please put your hands together and pop down your croissant and give Rajeev a very warm welcome.
Thank you, everyone. Thank you, Simon, for the kind introduction. I'm a hematologist, blood doctor. I'm based in Middlemore. Since 2012, I've been working there. So that's my background. I treat myeloma patients. That's a big part of my work. And many of myeloma patients get amyloidosis. They have amyloidosis as a complication of their disease. I don't have many AL amyloidosis patients actually on its own. I've got a few, but myeloma is my predominant specialty, and it's well known that AL amyloidosis is part of myeloma in about 10 to 20% of patients with myeloma. It looks like that. So it looks like that under the microscope. So amyloidosis is a general term referring to tissue deposition of various proteins. So it's not a single disease entity. So it's a variety of disorders. So this is a common term that we use. And there are three major types of amyloidosis. I'm going to be talking about AL amyloidosis only. So AL amyloidosis is one major form of amyloidosis. You can call it a blood disorder because it's amyloidosis forms here because of the deposition of the light chains in various tissues. And these light chains are produced by plasma cells. So plasma cells are immune cells. They live in the bone marrow and also lymph nodes. The function of plasma cell is to produce immunoglobulins or light chains. They are immune proteins. When plasma cells become abnormal, they tend to produce abnormal light chains and abnormal proteins, and that gets deposited in the various tissues. So that's what AL amyloidosis means. That's what AL amyloidosis is. So it's kind of blood disorder. The other two major types of amyloidosis, ATTR amyloidosis, Tim Sutton talked about that. And there are two different types, wild type and hereditary type. Obviously, that's not a blood disorder. It's completely different, and the management is completely different to AL amyloidosis. And the third type of amyloidosis that we commonly see is AA amyloidosis. That patients get AA amyloidosis as a complication of long-standing inflammation or infection. We are seeing less AA amyloidosis nowadays because we are treating the infection or inflammation very well. So the AA amyloidosis incidence has come down in the last 10-20 years. And the major feature of AA amyloidosis is renal dysfunction. And the treatment of AA amyloidosis is the underlying cause of whatever the infection or inflammation is. So it's not directed towards AA amyloidosis itself. I'll just restrict myself to AL amyloidosis. AL amyloidosis is basically a deposition of light chains which are produced by plasma cells or plasma cell clones. As I mentioned, plasma cells are immune cells living in the bone marrow and lymph nodes. Their function is to produce immune proteins And in AL amyloidosis, the tricky thing is that we can't detect these plasma cell clones. We can do various tests such as bone marrow biopsy and various other biopsies to detect plasma cells, abnormal plasma cells, but we commonly don't see them. And that's AL amyloidosis. That's less common. More common is we see myeloma, where plasma cells are quite numerous in the bone marrow, commonly more than 10%. And they also have amyloidosis. So they have a myeloma plus AL amyloidosis. So the second scenario is much more common. I would say 10 times more common than AL amyloidosis on its own. I would say AL amyloidosis is very tricky to diagnose than myeloma, much more difficult. And you have to have a high degree of suspicion to diagnose AL amyloidosis early. I just want to mention about MGUS because this is very, very important. MGUS, it's a long name to it, monoclonal gammopathy of undetermined significance. So this disorder is very common in patients who are more than 65 years of age. So if you randomly blood test patients people above 65 years of age, you will find this MGUS in about 5% at least, probably more than 5%. And they are otherwise okay, they don't have any other issues with it. They just have this abnormal protein in the blood that we can detect. We can detect light chains and paraproteins, but they are normal otherwise. They have no organ dysfunction. So this is very common. As I mentioned, 5%. And in AL amyloidosis, bearing that in mind, bearing MGUS in mind, accurate diagnosis is very crucial in amyloidosis. Why? Because AL amyloidosis can affect the heart, and the prognosis of AL amyloidosis, if it affects the heart, is bad, less favorable. And TTR also can affect the heart. And the treatment of AL and TTR, they're very different. AL amyloid, you treat the plasma cells, you target the plasma cells, while TTR is completely different. And MGUS, as I informed you, the MGUS is very common. So you can have a situation where there is abnormal protein in the blood and they have amyloid. So this scenario is very common, and that's why we have to get it very right. So you can have MGUS plus TTR amyloid in the heart, and this scenario is not uncommon. And it was not uncommon for patients to get chemotherapy in the past for MGUS, and the cardiac amyloid they had was TTR amyloid. It happened recently. So this scenario is not uncommon, and we have to avoid this kind of scenario. We need to avoid patients getting chemotherapy for TTR amyloid because they don't benefit from it. They only get the toxic side effects from it. So what's involved in diagnosis of amyloid? So you need to biopsy first, biopsy the affected organ. It could be kidneys, it could be heart, it could be other tissues. So organs involved, organs damaged should be biopsy, and you have to establish the presence of amyloid. And not only that, amyloid is just, as I said, as you know, it's a general term. You need to subtype the amyloid. And that's where mass spectrometry becomes very crucial. We need to perform mass spectrometry to subtype the amyloid. Mass spectrometry, unfortunately, is not a funded test. It's not a common test. It's a special test. We only have it available in Auckland University. We don't have it available anywhere in the country, I don't think. And it's quite a mission to get it done. Because it's not a funded test, you need to pay money to Auckland University, and it creates a lot of issues. I don't want to get into that. So mass spectrometry is very important when you have a diagnosis of amyloidosis. So that's how amyloidosis looks like under the microscope. So first step is identifying the amyloid using the stain called Congo red stain. So that's the standard stain we use. So Congruent identifies any amyloid, and then you have to determine the type of amyloid by doing mass spectrometry. It's very accurate. Mass spectrometry is very accurate. I would say specificity is more than 90%. What do I mean by specificities? It's very accurate. Mass spectrometry can determine the type of amyloid in more than 90% of the cases. The tricky thing is sometimes to determine the biopsy. Where do you take the biopsy from? Sometimes the organ involved is tricky to biopsy. For example, cardiac. If a patient has cardiac amyloid, it's very tricky to get a cardiac biopsy. We can get it done in Auckland, but it may not be possible in other cities or other towns. So you sometimes can do other biopsies, other organ biopsies, like such as fat pad. You can get a fat pad biopsy from under the skin in the abdomen, and that has a sensitivity of 60 to 80%. That can be done as a surrogate marker of amyloidosis elsewhere, but it's very specific. You can do bone marrow biopsy that has a sensitivity of 50 to 55%. So if we combine bone marrow and fat pad, the sensitivity or specificity goes up above 90% to as close as 100%. So we can't do organ biopsy, such as cardiac or renal, kidney. Then you can do fat pad biopsy and bone marrow biopsy. But we always recommend that organs affected should be biopsied. When do you suspect AL amyloidosis? There are different scenarios here. Common organs involved with amyloidosis are kidneys and heart and nervous system. So if you have a patient with protein leakage from the kidneys, protein leakage from the kidneys can happen most commonly in diabetic patients. So if you have a non-diabetic leaking a lot of proteins from the kidneys, we call it nephrotic range proteinuria. AL amyloidosis should always be suspected. And the second scenario is where you have cardiac dysfunction without a cause, a non-cause, unexplained heart failure with a thick-walled heart. You have to suspect amyloidosis. And you can have, if you have raised cardiac enzymes in the blood without an underlying heart problem, you always have to suspect amyloidosis. Unexplained hepatosplenomegaly, that's a technical term for big liver and big spleen. That's less common. And peripheral neuropathy, I would say, is reasonably common. Amyloidosis can affect the nerves, and it can cause what we call neuropathy. It leads to tingling and numbness in the tips of fingers and toes. Macroglossia, big tongue, can happen with amyloidosis. Unexplained facial and neck bruising, that also can happen with amyloidosis. I have a picture later on. And the most common scenario is atypical myeloma. We do have patients with, as I said, MGUS and myeloma. There are certain features alert us to the underlying cause of underlying diagnosis of amyloidosis. So we have to keep that in mind. That's more specific to hematologist. I'll discuss a few cases that'll be more helpful. We currently have it's not 47, it's actually 74-year-old man. He was unwell for many years, for more than 10 years now. Unfortunately, it was late diagnosis or delayed diagnosis. He was symptomatic from shortness of breath since 2011. He was worked up in private and public, and he was diagnosed to have sarcoidosis without a tissue biopsy. It was diagnosed based on the clinical, based on the symptoms, and also based on how it looked on the X-ray and scans. He also had lymph node enlargement in the chest. He also had a lot of lung changes and abnormal lung function tests. So the doctors concluded that he had sarcoidosis affecting the lungs. He had lots of other tests, including bronchoscopy. And I think biopsy was also done, looking for other things like granuloma and cancer or TB. The conclusion was he had pulmonary sarcoid, and he was treated with immunosuppression with a lot of drugs, methotrexate, other immunosuppressants, for the last 10 years, with no significant improvement. And incidentally, he had a biopsy of the palate from oral cavity. He had a biopsy in 2011 that had amyloidosis, but nothing was done about it. He was not referred to us or any other department for this. And 13 years later, in 2024, he had GR bleeding. He vomited blood. He ended up in the hospital. He had a gastroscopy, and no specimens were collected, but it looked normal. There was no bleeding spot, so they didn't do a biopsy. 3 months later, in August, he had another episode of GR bleeding. He had a Mallory-Weiss tear, meaning a linear tear in the stomach, and he had also other abnormal appearing gastric mucosa. Biopsy was done, and fortunately Congo red was stained, and that showed amyloidosis. So this time the case was referred to us, and I looked at the referral from the gastro. I dealt with that. So to me, it was suspicious for amyloidosis. Of course, we have a confirmed diagnosis of amyloidosis, but I wanted to do further testing. So he had full workup under us. We did full workup for bone marrow biopsy. He had full blood workup. He had abnormal protein in the blood, IgG lambda type. He also had erased kappa and lambda light chains, lambda more than kappa. He had bone marrow biopsy, looking for myeloma, underlying myeloma. He also had full body MRI stir. We always do that when we are suspecting myeloma. He also had cardiac enzymes that was normal, and he didn't have any features. He also had echocardiogram. He didn't have any features of cardiac amyloid. But most importantly, I requested mass spectrometry from the gastric biopsy sample, and that confirmed that he had AL type of amyloidosis. So obviously, this patient had gastric amyloid, AL amyloid. What's happening in the lungs is probably AL amyloid. We don't need a biopsy from the lungs because we already have a biopsy from the stomach. So we concluded that he's got 2 organ involvement, gastric and lungs, with AL amyloidosis, and he's been commenced on anti-myeloma, anti-plasma cell treatment. The name is Cybodex, 3 drugs, cyclophosphamide, bortezomib, and Dex. He just started first cycle literally a few weeks ago. So this scenario is not uncommon, unfortunately, because AL amyloidosis is a tricky diagnosis to make for sure. So if you don't have high degree of suspicion, you can easily miss it. Case 2, 60-year-old man with heart failure symptoms for last 3 to 4 years. He went to the GP multiple times with shortness of breath. Eventually, he was referred to a cardiologist, and he had an echocardiogram done, which showed left side of the heart thickened with preserved muscle function. That's always suspicious for amyloidosis. He also had, Dr. Tim Sutton saw this patient. Tim organized all these scans, or maybe Tim's colleague, all these scans looking for amyloid. The SPECT was done, DPD, the nuclear scan. That was positive, grade 3 positive, meaning the heart was lighting up on the nuclear scan. He also had cardiac MRI, and that also was consistent with the cardiac amyloid. Cardiologists concluded that the imaging looked typically of TTR amyloid, but as part of the workup, this patient also had the light chains, and that was abnormal. The lambda light chain was raised. That's why the patient was sent to us. He also had this raised cardiac enzymes. BNP was raised, troponin was raised. Interestingly, this patient had carpal tunnel syndrome. Left carpal tunnel surgery was done a few years ago, and currently he's got ongoing symptoms from right side, the carpal tunnel syndrome. Again, that's seen in amyloidosis, so you have to. The pattern is suggestive of amyloidosis. So, because this light chains were abnormal, specifically the lambda light chains was significantly raised, 117. That's very high, and kappa is completely normal with abnormal kappa lambda ratio. In the context, that's very important. Cardiac amyloid, abnormal lambda light chains. To me, that's AL amyloidosis. The pattern is typical of that. He also had other tests, electrophoresis, urine, and blood. So we found free lambda in both blood and urine. We also did bone marrow biopsy. He had myeloma, about 10 to 15, not a high plasma cell burden, but high enough to call it myeloma. We specifically did this T1114 as you heard it before. We commonly look for this this translocation in myeloma and as well as AL amyloidosis. That was negative. We did the full workup as you mentioned, including MRI. There was no myeloma lesions in the bone, but he met the WHO criteria for myeloma. But because the cardiologists were sure that it was TTR amyloid in the heart, and maybe he's got AL elsewhere, so I wanted cardiac biopsy. But in the meantime, we did bone marrow and fat pad. Bone marrow was positive for amyloid. Fat pad also was positive for amyloid. But I didn't do mass spectrometry on these samples because I wanted to know what was happening in the cardiac, because that's very prognostic. That changes the prognosis hugely if you have cardiac involvement with AL amyloidosis or not. So cardiologists did cardiac biopsy, and that biopsy was small. Cardiac biopsies are typically small. And the pathologist initially reported that, maybe there's amyloidosis present. I can't be 100% sure. The sample is too small for mass spectrometry. That's what the report said. But I wanted that specimen to be sent for mass spectrometry, and even if that was small, fortunately that came back positive for AL amyloidosis. Conclusive, it was definite. So basically, what was happening in the heart was AL amyloidosis, and it was commenced on Dara Cybody. Cybody is the funded treatment in New Zealand. Daratumumab is not funded. Daratumumab is a monoclonal antibody, and the patient decided to self-fund this drug. Dara is very expensive. It's about $10,000 per dose. And initially we load them with Dara every week for 8 weeks, and then it becomes fortnightly for the next 8 doses. So it's quite an expensive drug. It's currently not funded because of the cost. And just after one cycle, he achieved light chains normalized. The lambda light chains normalized from 117 to less than 20 something. And so he has achieved what we call hematological response. What we are actually waiting for is whether he will achieve organ response, cardiac response, whether his heart will go back to normal. Time will tell. And eventually my plan is to refer him for autologous stem cell transplant. That depends on his heart, because bone marrow transplant is a very intensive procedure. It involves taking stem cells from the blood that allows us to give high-dose chemotherapy to kill all those cancer cells or plasma cells, and we have the stem cells stored which we can reinfuse. So that's actually standard treatment for myeloma as well as AL amyloidosis, provided their heart and lungs are normal. So the heart and lungs have to be normal in these patients for them to go through this procedure. So time will tell whether he will be a candidate for transplant. So he's still under cardiologist who will guide us whether his heart is good enough for him having transplant in the future. I will come to that. AL amyloidosis, we can't cure it. We can only treat it. We need to clear all the plasma cells, all the remaining plasma cells, so that they don't produce the abnormal light chains. You want to wipe them out completely, so you don't stop in one cycle. I don't think that's enough. Someone, you can help me here.
Thanks for asking about the controversy of autologous stem cell transplantation. So before we had things like Daratumumab and Cyborg-D, transplantation was the standard of care, but it is, as Rajeev said, it's a very intensive treatment. So the question is, when you consider the cost of Daratumumab, it's an autologous stem cell transplant is a nice way to consolidate the gains that you've already made with the treatment that you have. Now, you can argue the toss both ways. There are people who are very pro autologous stem cell transplantation and those that are not. I think that when you are limited for what drugs you can access, both ongoing Daratumumab and at relapse, so this chap I don't think had an 11-14, so venetoclax is not will not be effective. So I think that it's reasonable to consider, but it is something that if you got 10 amyloidologists in the room, 5 would say yes and 5 would say no. So it really would depend on how well functioning the patient is, how severe the disease is, how young the patient is. I think this guy was only 65. So you can argue it really both ways. But autologous stem cell transplantation is probably the only definitive curative option. So, we know that if you're in a complete remission 12 months after you've had an autologous stem cell transplant, you will still be in complete remission 10 years later. So it's really full-on therapy. Did you want to have a quick chat about that at all?
Hi, I'm Kath Davies. I'm the National Patient Advocate for Australia. I had a stem cell transplant in 2019. I'm an intensive care nurse with a vast medical experience, and when they told me I had amyloidosis, I went, what the? I had no idea what it was. And I can honestly say that I went in very naively with the autologous stem cell transplant. But I am completely in remission, and I'm 5 years later. So while I recommend it, it will be probably one of the hardest journeys that you'll go on. If I relapsed, would I have it again? Probably. Even though it was the toughest thing I've ever done it all. But look at me, I'm here, I go sailing around the world, I travel, my daughter lives in Sweden, I go and visit her. Even though I have still ongoing problems, it's nothing like it was before.
Thank you. Okay, moving on. Sorry, I had to mention about one more scenario, which is not uncommon. I've mentioned 2 cases, one cardiac amyloid, one GI gastric amyloid. I've got 2 other patients currently on treatment for AL amyloidosis. They have kidney involvement. Unfortunately, they are on 2nd line or 3rd line of treatment. One patient is on 2nd line, the other patient on 3rd line. They had hematological response after the 1st line, but they didn't have organ response. Unfortunately, those 2 patients are going on, and they will need dialysis in the near future. So kidney is the other organ commonly involved, and we don't always achieve organ response, which is unfortunately, unfortunately the case with those 2 patients. What are the common clinical manifestations? Kidneys are involved commonly, heart, liver is involved. The Liver involvement doesn't lead to organ damage. I've not seen liver failure from liver amyloid. GI tract can be mild. So many patients don't have any symptoms from it. And peripheral nervous system, tingling and numbness in your feet and tips of fingers, that's reasonably common. Lung involvement, not uncommon, but it's not common either. Soft tissue involvement, carpal tunnel is very common. Macroglossia, it's very commonly described in the textbooks. I've never seen it myself. And skin, and a few other things, which are not common. These are the diagrams of macroglossia: big tongue, shoulder pad sign. I've never seen it. Raccoon eyes, bleeding in the eye area. I've never seen it myself. Principles of treatment. As I said, treatment is directed towards the plasma cell clone. We say that it's not curable but treatable. Treatment aim is to achieve hematological response. What do I mean by that? We need to normalize the light chains, abnormal light chains, so that we are preventing light chains being deposited into the organs. So that's the primary aim, the first aim. And the next aim is to achieve organ response, to see whether organs recover their function or limit further damage. But relapses are common, and retreatment will be required. And you have to tailor the therapy to the individual patient, taking into consideration the toxicities as they relate to the extent of organ involvement. What do I mean by that? Say, for example, if a patient has cardiac amyloid and you're treating with the standard AL amyloidosis treatment, expect more cardiac toxicities because heart is involved with amyloid, so they tend to get more side effects. Unfortunately, I had a patient who died of sudden cardiac arrest. He had cardiac amyloidosis and he was getting typical Cybodex. That's our standard first-line treatment. He was admitted to the hospital with, during cycle 1. He was having hematuria and blood in urine, and also he was unwell with fast heart rate and things, and he died suddenly. It has to be a side effect of the treatment. So they do get more side effects. They do get more gut side effects also if they have cardiac. If they have gut amyloid, they tend to have more diarrhea. They tend to get more nauseous. So you need to be careful. Neuropathy is very common in this group. They commonly have underlying neuropathy, mild neuropathy. And when you start treatment, certain medications that we give are neurotoxic. So they get more side effect, more neuropathy from it. So you need to be careful. And you have to have organ-specific supportive care to maximize the quality of the patient and minimize treatment-related toxicity. I won't go too much into detail with about treatment. So broadly speaking, there are two categories of patients. One, those who are fit enough to have transplant, and the other group is those who are not fit enough to have transplant. So those who are not fit enough to have transplant, so this group, the standard treatment is here in New Zealand, Cybodex, 6 to 8 cycles. That's what we typically use in New Zealand. We don't have Daratumumab. It's nice to have, but currently we don't have. So Cybodex is the standard. That's 3 drugs, combination of 3 drugs. If they are transplant eligible, then we do consider transplant. We sometimes do early transplant versus late. I don't want to get into details here, but they usually offer transplant after, say, 4 to 6 cycles of treatment. As I mentioned, in New Zealand we only have Cybodex, 6 to 8 cycles plus minus bone marrow transplant. Daratumumab is not available. When patients do relapse in the future after first line, we have IMiDs. That's what we typically use: lenalidomide, pomalidomide, thalidomide. Sometimes we use chemotherapy agents such as melphalan. We don't have access to venetoclax, as Simon mentioned. Venetoclax is a very good drug in patients with AL amyloidosis who have T1114 translocation, but we don't have access to venetoclax in this group. So this is the last slide. So early diagnosis is crucial. It requires high index of suspicion. And before you start treatment, you need to confirm the diagnosis. You do mass spectrometry for sure, and differentiate from other forms of amyloidosis. You establish the extent of amyloidosis, extent of organ involvement, cardiac, liver, GI tract, other, and assess other medical issues that patients may have, and then start treatment once a diagnosis is confirmed, and refer them to transplant if they are eligible. And we don't have DARA. It's a nice to have in the future. Hopefully we'll get it. They have decided not to fund Daratumumab in myeloma patients. Then they've made it very clear. Pharmac has made it very clear to us. We've been asking Pharmac to fund Dara for the last 6 years, but this year they've said that they're not going to fund it. So it's going to be many years away. Yeah, that's all I have. Thank you.
Time for questions? Yeah.
An important thing in making diagnosis seems to be the mass spectrometry, and that's not funded. How much does that actually cost?
$1,100.
No, it is funded. We have to apply to the local DHB, as it used to be, that you live in, to get it approved. But with the example that Rajeev talked about, no one would take responsibility for doing it. So we were trying to get someone to say that's okay to do it, and eventually got someone to say, I got one of the cardiologists to do it, but it's typical of the red tape that we all face with Te Whatu Ora. There were all these micro barriers, because as you heard, time to diagnosis is the most important thing, but there's all these micro barriers that get raised. So it is funded. You can get it from your DHB. In Australia, they don't have mass spectrometry available, so it's really cool that we have it available here. But it's just knowing the pathways. You have to navigate the red tape, but you can get it fully funded.
It's bizarre how things are. So we have Daratumumab, but we don't have mass spectrometry. So when it comes to typing, what we have to do is do the old-fashioned staining of the slides, and we're only certain in about 70% of cases. So Peter Millay in Brisbane's been trying to set that up. It's cost an absolute fortune. It's still not really that functional. So we have to send our samples across to the Mayo Clinic in the States for $2,500 US. Now that I know it's only $1,100 in Auckland.
So it doesn't cost to the patient, but DHB managers have to approve this. So the money comes from their budget. It's not a free test. You go to the lab, you get the blood test done, you don't pay the money to it. So, but here the money comes from the managers, from the DHB. Yeah. And the process is quite tedious.
What are the minimum requirements that a patient would need to get the stem cell treatment?
Heart function has to be normal, lung function has to be normal.
Normal as opposed to 100% normal, or being able to do something?
It's decided on a case to case basis, so you can't generalize this.
And I have dodgy lungs.
Still does.
It's like, I think it's from my perspective, it's whether you were fit or not. You know, if you were reasonably fit and you kind of met their criteria roughly, they would do it. But it's something from a nursing perspective, is something you really need to be ready for, you know. It's something that you don't go in blindly like I did and thought, oh, this is going to be a walk in the park. As I said, I'd do it again, but be mindful that it's not a walk in the park.
I think one of the things is that there are international guidelines as to, you know, when you should do it and in whom you can do it. When I say I use the plural international guidelines because there's about 6 out there and they're all slightly different. So it's really, you've got to assess the patient in front of you. You know, you need to do some functional tests. You need to sort of see how physically well they are, but I also think that there's a psychological element as well that you really have to factor in as well. But it's also, well, I think it's a reasonable question to say, well, if I'm in a complete remission, do I have to do it right now? And so sometimes a patient won't be fit enough for a stem cell transplant, but because they're in a complete remission, you wait 12 months, their heart gets better, they feel better, the light chain starts to come up, and then you jump in with the stem cell transplant. So there's a lot of factors to think about when you're talking about stem cell transplantation. Yep. Yeah, definitely. So, Rajeev sort of inferred this, but there are various staging that we use called the NAC staging, or NAC, and that's based on things like what the percentage of light chains there are, whether it's symptomatic myeloma or just an MGUS, how much heart's involved. That will determine what the likelihood that you've going to have long-term survival. So if you're in a complete remission and you've only got stage 1 disease, then you might not need a stem cell transplant, and because you'll do quite well just on Cyborg-D. And usually what I would do is I'd collect the stem cells if a patient's under 70 years of age and wait and see, and then if they relapse then maybe jump in, but we might have done the job. That's rare, but it does happen. If you've got stage 3 disease, then you might be too unwell to have the transplant. And one of the things that we do is we collect the stem cells. If a patient actually really crashes and burns while we're collecting the stem cells, I'm like, if they struggle to collect the stem cells, then they're not going to tolerate the transplant. So all bets are off. But especially with, say, renal amyloidosis, that you could be peeing out a lot of protein in your urine. That can make a stem cell transplant quite challenging because of fluid shifts and things like that. So if you get a good remission and you wait 12 months, often the amount of protein you're leaking out halves, and then it's safer to do it. So I must admit, unless a patient's got really rampant symptomatic myeloma, I usually wait 12 months to try and get the patient fitter physiologically, psychologically, just see what their disease is doing, but collect the stem cells because that's a great insurance policy. It's nice to have that in the bank. Unfortunately, stem cell transplantation is not something that we can really offer patients over the age of 70 because really the treatment is worse than the disease when that happens. So we sort of, again, it's on a case-by-case basis, but it's a tricky science.
If patients have myeloma, they definitely should have transplant.
Yes. If you've got symptomatic myeloma, then you should definitely have a transplant if you can, if it's safe.
In terms of the heart side, in terms of the heart side of things, organ response takes a year or two.
Yeah.
So you can see the bloods look better, but it takes a while for everything else to get better. My understanding is the kidneys still get worse, even if you've had, so if you've got kidney amyloid, you still get worsening renal function. But from a heart perspective, it may be a year or two before you're really getting the heart turning around. And you can look on an MRI, and after a couple of years you see the amyloid is starting to disappear. So those measured, I showed you the measurements of expansion of the heart, that will actually improve with time, and on echo you can see the elasticity of the heart improve. One of the things that is difficult to appreciate is the heart getting less thick, and it's amazing. You can see on echo heart function improve hugely with chemotherapy, which is an unusual thing because light chains are directly toxic to heart muscle, but it's like it takes a year or two, and you're looking at your blood tests, so the troponin and the BNP. So for stem cell transplant, you want those down in the normal range because that predicts your body or your heart is going to cope with the stem cell transplantation. And if you feel well, the heart works okay, and your bloods are good, that is essentially, for having a stem cell transplant when you've had cardiac disease, is as good as it gets.
Yeah.
But if the blood tests are abnormal, the risk is higher, so you're a bit more wary in that situation.
I still remember a patient who was 50 years of age at the time of diagnosis. He had myeloma and cardiac amyloidosis, and his heart function was not good. So he was not transplanted. He was refused by the transplant team, and then 9 months later he had a transplant at the end. because cardiac function improved. So we re-referred and they accepted. He's still doing well. He's 8 years later.
Do their schemes fund for such drugs or no?
No, very limited. Only $10,000 per year is covered by insurance. So it's not covered even by insurance.
So I was just going to say one thing. I probably just want to let this audience know is that Daratumumab, it's a great drug, very well tolerated, but it's not the be-all and end-all. So you can, as you can probably tell, you can actually get very good results without Daratumumab. For instance, the French approach, even though they have Daratumumab, they will often give a cycle of Cyborg-D by itself and see whether they've actually responded. And if you're doing very well with Cyborg-D, then they don't break open the Daratumumab vial because of this outrageous expense. Because there's no... I guess the thing that I would say is that if you can't access Daratumumab, it's definitely not the end of the world. You can do really well. I don't think you've had Daratumumab, have you? Yeah, and look at how fit Kath is. She makes me tired. So, so it is just one of those things that if you really need Daratumumab, if you've run out of all treatment options, then maybe breaking open the piggy bank might be an option. I'll talk more about that tomorrow, but about various possibilities. But we faced, a life without Daratumumab in Australia for a while, so we're quite used to these sorts of challenges. But it's just trying to work out when to try and access these high-cost drugs if you need them in a really strategic fashion, and that certainly is nuanced.
So just leading on from that, for somebody who's had stem cell transplant and subsequent relapses and will need Daratumumab probably because of running out of options, when that happens, my free light chains start drifting up, is there merit in, instead of the loading dose of Daratumumab, going straight into fortnightly dosing because of the cost? Because it's clear that we're not going to have this funded for some time.
It's a tricky. Daratumumab is always used as loading, like weekly, followed by fortnightly, and then monthly. So we'll be going against evidence if we do that.
Okay.
So I think that you certainly need a certain amount of drug in your system in order to get the dose that you need to be effective. I wouldn't probably cut back on the initial ramp-up dosing, but I would have thought that as soon as you get a CR, then maybe just go to monthly dosing if you need that. So, what was that? Oh, complete remission. Yeah, sorry. Thank you, Kath. So she keeps me on the straight and narrow. I'm being told to wind up by Jamie, and you never want to get on the wrong side of Jamie Christmas. So if you'd all join me in thanking Rajeev for a great presentation.